So good morning, everyone. My name is Brianna Yoakum. I'm with the Washington Alliance for Quality Recovery Residences. I'm in charge of accreditation for Walker, and I'm joined here by Cameron Fordmeyer. He is going to be our presenter today, and he's going to be talking about understanding depression and anxiety. And so we will have this recorded, and we are going to put it on our website. Cameron will go into some disclaimers about that and how we can keep sensitive information protected. But we will also have the slides passed out as well for everyone who attended in an email today. So feel free to put any questions you have in the chat or unmute yourself and ask them throughout our presentation. And with that, I want to introduce Cameron. So Cameron Fordmeyer has worked in behavioral health since 2001. He has a master's in education and counseling. Cameron has been a designated crisis responder since 2010 and managed crisis services for Benton and Franklin County Jail, mental health, and the prosecutorial diversion program, and as well as a mobile outreach team from 2015 to 2021. Currently, Cameron is the regional administrator for the Recovery Navigator program and assisted outpatient treatment with Columbia Behavioral Health. He is the owner and operator of Awareness Counseling and Training, and Cameron is a board member for the Benton Franklin Recovery Coalition and chairperson for the Youth Suicide Prevention Coalition. So we're so grateful to have you, Cameron. Always great having you share your expertise with us. So with that, I'll pass it on to you.
Thank you.
Yeah.
Everybody can hear me okay? Maybe a thumbs up for those of you who can see. Perfect. So the sound. All right. So today we're talking about depression and anxiety, but it isn't going to be from a clinical or a college educated type course. I'm going to try my hardest to not use clinical jargon or acronyms. This will be more real world applicable on how you would be working individually, maybe as a peer, or a direct care line of service that you're working with the individual. So if I do start talking in acronyms or you hear any clinical jargon, feel free to raise your hand or ask. I can see everybody's pictures if you're up. So if you do raise your hand in the kind of video part, I can see that. You can also put things in the chat. I have that up as well in the PowerPoint. So feel free to do that at any time. There will be a question and answer section at the end. But if you would like, you can put those as we're going anytime, and I'll stop. And if it's going to be covered later on in the slides, I'll maybe kind of give a hint that we'll discuss that later on, but I'll acknowledge that you had put it in the chat as well. So moving on, again, thank you for the introduction. Those things are all wonderful as far as degrees and leadership positions, but some of the stuff that was the most valuable was my time in direct care. And so I had started early on, right out of high school, in community protection group homes. And so that was a crash course into behavioral health, because we had individuals with developmental disabilities, chronic mental illness, severe substance use disorder, and they had committed high-level crimes. And so these were individuals who, if you put them at Eastern State Hospital, they would be taking advantage of people. But if you put them in, prison, they would be getting taken advantage of. So what do you do with those individuals? You give them to a 18-year-old kid right out of high school who is expected to monitor them 24/7, right? So that was a huge learning curve for me. And as I was getting my bachelor's degree, I got to see the things that were going on, how internal preoccupation actually looked when somebody was hallucinating or when they were having paranoia and delusion. It was something that I actually had the luxury of seeing firsthand versus learning in a book. And so the things that you guys are doing in the real world field is extremely valuable. It will be, hopefully academia doesn't come after me, but more valuable if you choose to get a degree or do a higher level of education. So the more real world experience you can have and tailor make to things like this, the better you're going to be. And so after doing community protection group homes. I ended up working on the psych hospital after getting my bachelor's degree, and that was even more valuable, seeing people who did meet the criteria for detention. So when they were truly a danger to themselves, a danger to others, or gravely disabled, and being able to separate the two on how you look outpatient versus how somebody who needed to be inpatient would present, right? And the different challenges that come with that. After that, I became a crisis counselor, and that's when I really started getting into instructing. So I'm also a youth mental health first aid, adult mental health first aid, fire and EMS, management of aggressive behavior, which goes through de-escalation training. And for a period of time, I did some adjunct professor stuff at Columbia Basin College. So that is kind of the stuff on me. So I do want to do some disclaimers before we get into any of these trainings. So this training specifically is intended for awareness and information purposes only. It's not actually a substitute for actual treatment or self-help strategies, right? We do want to empower everybody to not just seek out education, but actually apply these things to what works for them. It's not a one size fits all. This presentation is also not intended to solicit business for my training company or personal or my company, anything like that. And if we do talk about specific modalities of treatment, I want to be very clear that I support all treatment modalities, whether that is harm reduction, whether that is medication assisted treatment, whether that is traditional therapy, med management. I believe in individualized treatment plans for everybody. So if we do get talking on some of those, if it works for your individuals that you're serving, I support that. So I'm not taking a stance on any specific modality or training. I am a behavior professional, but what that means is we are not actively engaged in a therapeutic relationship. So I do want to bring up the limitations of confidentiality. So if you do have a personal story, or you do have a story about an individual you're working with, this is being recorded, so keep that in mind. We don't want to disclose any personal identifying information or any healthcare information. So maybe if you do have stories which are very helpful and you do want to bring up an example, maybe make that vague to where we're not able to pinpoint who you're talking to. Again, always check with your governing bodies on resources when you're experiencing behavioral health challenges, and that includes yourself as well. Your employer might have some things for you, and this is not going to supersede any licensure or policies and procedures that you are already governed by. And most importantly, while we do this, please be kind to yourself, your coworkers, your loved ones. Right now is a time where things are getting hard in all realms of life for a lot of people. And so we want to just practice that kindness and try to take a step back, because this is a field that is filled with burnout and you hear jadedness, you hear compassion fatigue, all these things. So we really want to be kind to yourself as well as the population that you're working. Any questions, comments, or concerns so far with the disclaimer section? Pretty self-explanatory. All right. So moving forward to the learning objectives. So what do we want to accomplish while we're here? So for one, we want to learn the difference between mental health problems and a diagnosable illness. And we'll talk more about that. The worst thing that we can do is when we are trying to help somebody is practice outside of our lane, right? And so we'll discuss who is able to actually diagnose, who we should be referring to if a diagnosis is necessary, and also clarify between, like I said, what is truly a mental health challenge, because we all suffer from mental health challenges. We all have stressors. We all have bills to pay. We all have relationship problems. We all have anniversary dates that come up whether we want them to or not, right? So there are all things that we all deal with. That doesn't mean that you have a disorder, right? That means that you're suffering from a mental health challenge. They present very similar, but there is a difference between having a disorder versus having a challenge. So we'll talk about that. We'll also talk about the similarities between depression and anxiety. Depression and anxiety present very similar, and it's one of those things where you're saying, well, are they depressed or are they anxious? It could easily just be both. And we'll talk about why that is, how you can't differentiate between the two, but how you can provide similar support. And then there are some ways that they present a little bit different, and we'll talk about that both. For the signs and symptoms of depression, it's important that you realize what those are. So we will not only present on the signs and symptoms of what depression and anxiety looks like, but how you differentiate between signs and symptoms. One is a sign that is observable, things that you can see. The other one is a symptom, how the person's feeling, right? So we'll look at the two and how you can maybe draw some of those things out to gather that information. One of the more important things, and however many of you are familiar with ACEs, right? I think most people that's gained some traction have maybe heard what that is, not the ace on a card, but ACEs is adverse childhood effects, right? And so risk factors, that makes a lot of sense for us when we talk about youth growing up, about the risk factors but there are also risk factors for us as adults and as young adults. Moving on into older times of retirement and the geriatric population. So there are risk factors that we're kind of gone with as a childhood, but then there are risk factors that go out throughout our life too. So we want to do our best to recognize those risk factors, but also be aware and limit the amount or the exposure that our clientele or the individuals we're serving are going through as well. So we'll talk about the risk factors. On the flip side of that, we'll also talk about protective factors. And then the last piece of that learning objective is how to help someone experiencing these symptoms. So we'll talk about maybe how to structure a conversation with that. We'll talk about, which is usually just as important of what to do as what not to do, right? So we'll also talk about some helpful hints on what not to do. And then we'll break that down into the professionals that would be helping that and any questions or comments. So I think a lot of these are more valuable if you participate and ask some truly questions, and I encourage that. If not, no big deal either. We can just kind of do more of a psychoeducational or kind of a college-based course too. So let me know. Don't hesitate to ask. There is no dumb question at all, I promise. I've heard them all. So moving on to what is a mental disorder, right? When we start working in this field, the first thing that I felt like I wanted to do was start diagnosing myself, right? Then I wanted to start diagnosing family members and diagnosing coworkers and diagnosing everybody under the sun, right? I want to encourage you not to do that. That is probably one of the worst things to do. I've looked on WebMD and all of a sudden I have everything that you could possibly have. I think I have cancer, I have AIDS, I have everything, COVID on top of that, right? So we're not doing that. I do want to give you the clarification on how we break that down versus challenge and what makes a mental disorder. But even then, I want the emphasis to be on we are not diagnosing. There are only very specific people who are able to diagnose in the professional realm that have licensures to do so, or at least a provisional diagnosis when you're talking about crisis. But to be honest, diagnosis is mainly for insurance companies. They're for a guideline of treatment, right? They are something so that people can get services paid for. Sometimes they're beneficial for people to have a name to what they've been going through in their experiences. Other times it's just a label and a stigma, right? So whether we agree with diagnosis per se or the benefits of having such or lack thereof, we just want to draw the conclusion or the difference between what a disorder is versus a mental health challenge. Okay. So when we're talking about mental illness, and this also rolls into any type of co-occurring disorder, so substance use on top of that. When we say behavioral health, it's an all-encompassing term for all of that. So a mental illness or a mental disorder is a diagnosable illness that is diagnosed by a psychiatrist, a physician, psychiatric nurse practitioner, a psychologist, or a licensed therapist. You do have some positions like a designated crisis responser who don't maybe meet those definitions, but they do provisional diagnosis that to access certain services, and then they'll get more of a finalized from there. So the main thing to take away from this is we are all peers with lived life experience. We have all had some form of trauma, whether it was in the abuse category or whether it was deaths or loss. We've all experienced some of that, right? And that's kind of the common theme that we share, regardless of what side of the table we're sitting on or who has the keys. We've all experienced that. So everyone in life will go through mental health challenges. You will all have difficulties and adversity to overcome. So that doesn't necessarily mean that somebody has a diagnosis. If I have, I worked for a company for 13 years and it was a good split. It was that one got fired or I was disgruntled. After 13 years, I decided to come over to Greater Columbia Health. That was a loss. That was 13 years of relationship building and 13 years of clients and positions. And that was a very hard time for me. And I struggled with that and the transition. But that was a mental health problem. It didn't lead into some of these other things that we're talking about. So it is diagnosable mental disorder if that specific problem or that accumulation of issues impacts and affects that person's ability to think, their ability to state and be in control of their behaviors. So if your thinking, your emotional state, and your behaviors have been severely impacted, it might say that we are leading down that road, right? And that can still be a mental health problem if that doesn't stop or doesn't subside or get better. And in a 2-week window, we'll draw the line right there. If you're still feeling those ways in 2 weeks, it might be worth to start talking to somebody, or if you're working with somebody, start piquing up your interest around that. The other one to consider is that it disrupts the person's ability to work, obtain employment, or keep employment. This includes school for anybody who's maybe in college or a youth that's in K through 12. Carry out their daily activities, meaning take care of their hygiene, take care of all of their bills, mowing the lawn, brushing your teeth, any of those things. And the other one is engage in meaningful relationships, right? And that is specific to the person on what meaningful, whether that's having friends, having coworkers over, or engaging in romantic relationships. So if the person's ability to work and they have been having trouble at their place of employment, if they are constantly being written up, not showing up or not performing to the expectation, in school, if they're not turning in assignments on time, if they're not meeting deadlines, right? That is something that we want to pique our interest up. If they are showing up with appearance disheveled, right? They're unable to take care of their basic needs. They're having trouble with food. They're having trouble with their hygiene, any of those type of things, or meeting certain requirements of maybe they have kids who have sports and they're not taking their kids to sports. If they're supposed to be attending parent-teacher conferences and they can't do those. And the other one is, we all know that person who will say it's the sheriff's fault, it's the school's fault, it's my partner's fault, it's everybody's fault. But the common denominator is that they are having relationship problems with all of those people in their life, right? So that is where, outside of a DSM clinical diagnosis meeting 5 out of the 7 criteria for a diagnosis, that's the quickest way to say, is this somebody who's dealing with a mental health challenge and they're dealing with some things in their life, or is this something that's more of a disorder and we need to look at potentially encouraging some treatment for that? All right. So again, real quick, we're not diagnosing, but we are making the referral. We are paying attention. So does it impact the person's thinking, emotional state, and behavior? And is work, their daily activities, and relationships affected? That's the main takeaway from here on how we're going to distinguish between mental health challenge versus a legitimate potential disorder. I do have the chat up and can see that as well. On. So why do we raise awareness? Why do we even care about depression and anxiety, right? Why should we learn about these things? Well, the main one is that they are very common. Okay, this is anxiety disorders and substance use disorders are typically the ones that most people, when we look at the United States, suffer from, right? And those are just the people who are brave enough or willing enough to go seek treatment. There are plenty of people who will not seek treatment, or for whatever reason. Maybe that's stigma, maybe that's access to care, maybe that's a financial issue, maybe they live in a spot that doesn't have public transportation, whatever that means, right? But they are the most common when we talk about them. So anxiety, followed by substance use disorders and major depressive disorder, in those orders are the most common disorders that we will be dealing with in our career, or what individuals throughout their life will be dealing with. So there is still a stigma associated with mental health problems, right? When I was growing up, it was a, don't be a wimp, pick yourself up, walk it off type thing. Boys don't cry, you don't talk about those things. So I kind of grew up knowing that there was things that bothered me, that there were issues that I had, but you just didn't do that, right? And we are getting better about that. You can see that in when it comes to more of the masculine sports, the UFCs, the National Football League. There are more awareness campaigns about this. So things are getting better. So I don't want to harshen, kind of on the system that we're not, but it doesn't change the fact that there's still stigma attached. And that can be a cultural thing, that can be a race or ethnicity thing, that can be a gender thing, whatever that may be, the stigma still exists. So if you can, we want to always encourage awareness about these topic areas. So if you are in work, encouraging people to seek out treatment, seek out help, make a safe place within your working environment or within the homes that you're working in, that you can open the dialogue to have these conversations, right? That it isn't a sign of weakness, that it isn't a sign, of something wrong with it, that we all go through these things. So many people are also not well informed about mental health problems. They're also not well informed of what resources exist. And you see that in your own communities. We will have a giant MDT meeting and somebody presents a resource and everybody in the room is like, what is that? I've never heard of that, right? So not only are people not well informed about mental health problems in general, and maybe getting their information from social media, which is probably not the best place to get it from, but they're also not very aware of the resources around them. The one thing that we also want to do this for and why we're doing this is that professional help isn't always on hand. You may be in a remote location. You may be in a spot that doesn't have access to crisis workers or doesn't have access to therapists or med providers. And so you're that line of support before it even gets to a clinical office, right? So it's important to know these things because you may be providing support for somebody until we have to do a warm handoff to a different line of service. The other one is that people with mental health problems often do not seek help. And that may be for a variety of reasons: a distrust of the mental health system, a distrust of symptoms and systems in general. That could be barriers to that. So while we're doing this is that you're going to be that first hand, that first contact, right? Or maybe the person who develops that rapport with the person till they feel comfortable actually talking about some of these things. So for individuals who are uncomfortable seeking out help, you may be that help. You may be that first line for that person. Again, so awareness is simply putting it out there, right? Giving them some knowledge. And we'll talk more about this in there, so I don't want to dive too much into it now. But there's a big difference between raising awareness and providing information than there is telling people what to do or giving your opinion, right? So we'll talk more about that later on in the slides, but that's what we want to do when we are raising awareness about depression and anxiety, is we are simply providing facts and giving that person hope. So let's talk about depression and anxiety specifically. So why we are including them together, and we talked a little bit about that on the first slide, is that they frequently co-occur when it comes to symptomology. Okay. If the person has one diagnosis, it's likely that they have another, and we call that comorbidity. So if I am so depressed that I am trouble getting out of work on time, right? And now I know that my boss is going to say something to me. I know that my project didn't get done. I'm going to feel very anxious about that, right? Now maybe I just won't show up at all, okay? So I stop showing up. Now I have financial potential issues if I'm going to lose my job. Now I have a bunch of other issues on top of that, and maybe I start self-medicating, right? So what I mean by that is not going down too much of the rabbit hole, is that if you have one disorder and it goes untreated or it goes unnoticed, it is likely that you will develop a secondary disorder or another one, right? It's very rare that somebody who has a legitimate disorder only has the one disorder. So when we talk about depression and anxiety, they frequently co-occur and they frequently commingle as far as symptomology, but also they go hand in hand. So if somebody is depressed, it's safe to say they're probably also anxious. If they're anxious, it's safe to say they're also depressed. So depression and anxiety have similar signs and symptoms, and it's very difficult to tease out. For example, feeling restlessness, right? Or feeling hopeless or helplessness. There isn't a specific type of restlessness that is associated with depression, but not anxiety. It's the same feeling. It's restlessness, right? Same with appetite changes. If my appetite is affected and you've been asking and say, hey, how have you been eating? And I say, I don't feel like eating at all. Oh, well, that's the depression not eating, not the anxiety not eating, right? Or the opposite. They eat too much. They're binge eating. They're trying to seek comfort. Well, is that an anxiety thing or depression? It's both. right? So when we talk about that, it doesn't mean they are the same diagnosis and that they will always be that way. It just means that when you're hearing these things, you're not going to be able to tease them out and direct somebody for one or the other. Okay. So due to depression and anxiety being very similar, they're going to co-occur with symptoms and probably co-occur as far as the disorder. So let's talk about the types of mood disorders, because depression does fall into that, right? So we have major depressive disorder is the most common one that people understand and know, right? There are other forms of depressive disorders, but that's the major one that you're going to hear. Bipolar disorder is also in there. Bipolar disorder can also be categorized as a psychotic disorder due to the mania and the parts of potentially not sleeping, putting somebody in a manic episode, pushing them over into more of a psychotic state. But there is a huge depression component to bipolar disorder. So we also include that in there. There's postpartum depression. So that was one of the things that seeing on the psych hospital not only broke my heart, but really opened my eyes to a thing that I'd heard about it, never seen it. So if you are working with individuals who are pregnant or soon to give birth, that is something to pay attention to. Even if the individual comes from a good family, a good home, has minimal risk factors, has a bunch of protective factors, that doesn't change the fact that they are at risk for postpartum depression. When your body is flooded with a bunch of different hormones and all of a sudden those hormones are no longer there, you can take somebody who had a good family, good structure, good resources, all of a sudden they're thinking about jumping out of a window with the baby too, right? So we do have to keep that in mind. That's not something that happens to everybody, but I've seen it happen to people who you wouldn't think it happens to, right? So that's something to just peek up. The other one that kind of gets scoffed at a little bit is seasonal affective disorder. Okay, so we call that kind of where people who live in Seattle or individuals who are in Alaska who go through lack of sunshine or times of darkness, even when the season changes, right? A lot of us go to work, it's dark. At work is when the light is, and then when we get off, it's dark again, right? So we still have that lack. So seasonal affective disorder, you can use light therapy for that. So those low light boxes, any exposure to getting out is important. So encouraging those activities. Even if it's a cloudy day, just the simple fact of being outside does help with that. So if we can encourage our individuals that we're working with to just simply get out and go for a walk, some of that can be a lot more beneficial than staying inside and doing some art or doing whatever else they would do it. So when we talk about seasonal depression, it's also called SAD, seasonal affective disorders. We're doing that. Okay, and then we won't get too much into these. I just want you to get thinking about the different diagnoses because we could spend all day going through the DSM talking about different ones. So those are probably the top 4 that you're going to be dealing with, or at least working with individuals who are having symptoms from. So let's talk about anxiety disorders. So the most common one is generalized anxiety disorder. And I'm going to ask the group, why is anxiety disorder the most common, but also why is it the most common one that people feel comfortable seeking out treatment for? Maybe put your answers in the comments, or you can even get off mute and just say those. But why out of all of our diagnoses, why is generalized anxiety the most common one, and also the one common that you actually seek out treatment for? Because it's not that bad. Yeah. After that's
or to like it's stigmatized,
yeah.
Just general anxiety. There's no like real specific, or I have anxiety when I drive. I get anxiety when I meet with or in the grocery store shopping, because there's too many people. There's not a general anxiety. I think it looks better.
Yeah, no, you're exactly right. There is less of a stigma, and everybody has anxiety. That's no big deal, right? It's not that bad.
Right. I think that's part of the reason, because it's so common and everybody is anxious in one situation or another. So because it's so common and because we all experience it, it's easier to deal with and easier to admit that you struggle with it.
Hmm? Yeah, so you guys all had good answers. Environmental factors, because everyone has it. Anxiety serves as a survival function, which is very true. It's more common. It's been humorized in pop culture. True, right? It's one of those things that everybody, oh, I got anxiety. I got to take my Xanax, right? You hear that all the time. Getting on a plane, gonna have to pop my Xanny. You can cover a lot of things. Yeah, I can. My husband had this around people. Yeah, all these statements are very true. So yes, more common, and term generalized anxiety seems more accepted. Yeah, it's not a big problem. It's just generalized anxiety, right? We all have that. Okay. Um, so anxiety isn't that bad, but I have found that it's very disabling and underrated because of common. So Oliver, you hit it on the head though. So even though it's more acceptable, it is one of the harder things to deal with in your life. And it affects so much around you. It affects your thinking. It affects your physiological being, right? You can start having more of a kind of a ghost pain or a ghost's physical symptom that you go to your doctor for, and we'll talk more about that one. And then Drake, LOL. And I think it should be considered a MMI. Oliver, talk a little bit more about that if you can.
It seems like it isn't considered a major mental illness, but I think it is a major mental illness. And I've been doing this for 30 years, and in that time, people have learned to find ways to manage and live with their psychosis or with their mood swings or with, whatever their significant challenges are. But anxiety, it's like bindweed in the garden. It never goes away. It's always creeping in. You're always, with some of the people I've worked with over the years are really struggling to manage despite their best efforts. And it can be really incapacitating. I mean, I had a guy in a session once have a full facial spasm while he was, recounting an experience of anxiety earlier that day. I had one guy come in and says, it's so weird. It looks like there's an invisible pitcher of water on the top of my head. It's the only place I sweat when I'm having these bouts of anxiety. And therein again, he was talking about it, and it did look like just the very top of his head was sweating profusely, and it looked like there was an invisible pitcher of water being poured on his head. So really intense, somatic manifestations, and just so hard to work with, even with really good CBT and emotional support and all of that. So I think it's much more disabling than people want to acknowledge.
Yes, and you are spot on, right? Now, like we were talking about before, why it's the most common because everybody does, but that doesn't mean that it's the easiest to deal with, right? It also, people seek that out because, just like you said, it's very crippling and it's hard. It's hard to maintain healthy boundaries and healthy relationships. It's hard to be present in your loved one's life. It's hard to be present at work or school, or just to even getting your groceries, right, and filling up your gas. I mean, this is something that can be so crippling to individuals that when we talked about how do we specify between a mental health challenge and a disorder, anxiety is that. It literally affects all realms of your life. It's affecting your work, affecting your daily activities, it's affecting your relationships, all of those things, right? So generalized anxiety, the most common, but also one of the most crippling things. So thank you for everybody who piped in there. That was very helpful. The other one that we have is that we see as obsessive compulsive disorder, right? And that can be characterized by either a psychological compulsion, right? If I don't do A, B will happen. Or it could be a compulsion to do specific things or repeated patterns. So it can be a potential problem similar to generalized anxiety disorder, but as long as you can control your environment, you control your patterns, it's less of an impact. It can't make extremely hard to treat when somebody feels like if they don't do it, something bad will happen. And then you're having to talk to that person on working with them on, well, do you want to try that? Like let's work with that. And no, if somebody's really fixed on that something bad will happen, or I'll get germs if I don't wash my hands a certain way, so that can be very challenging for people as well. Other ones is panic disorders. Has anybody experienced a panic disorder in here?
I have.
How was that? Do you feel comfortable enough describing how that made you feel?
Sure. I struggled with panic attacks in certain situations, especially if I was in isolation. far away from, going through the woods or drives in the woods or far away from my home. I struggled with that for almost 20 years.
How did you learn that the difference between having a panic disorder and having a medical emergency?
It took a long time, but eventually, one of the things, I know this sounds crazy, is I thought I was having an asthma attack, and I learned if I took my asthma medication and it didn't fix it, I was definitely having a panic attack. But eventually, I found a lot of tools that helped.
Yeah. So one of those things too that we can do in the meantime, if we don't know, right, you're not going to know. Like you said, is it an asthma attack, right? Some people feel like they're having a heart attack. Some people have described it as similar to feelings of having a stroke. You're not going to know, right? Unless you're somebody who has experienced it before. And that is one of the questions that we want to ask somebody. Is this something that you've experienced before? And if it is, and they're similar to, then they say, have you had panic attacks before, right? At least that helps them for that offhand chance that maybe they are having it. If not, we have to treat it as a medical emergency, right? So you have to treat it as such. You don't want to bank on that being a panic attack when there's something else going on. So we have to treat it as seriously as possible. But the one thing that we do want, and whether that's 4 square breathing, whether that is any type of breathing techniques that right? I don't recommend that you breathe into a paper bag like they used to show. But helping that person control their breathing is one of the things that we can all do, regardless of education level or regardless of comfortability level, is to help that person through that process. And then, of course, ask if they need assistance in other realms, right? And then PTSD, so post-traumatic stress disorder. The other one that we're not going to get too much into PTSD, into trauma. That's a whole separate topic. We could talk about that all day long. And trauma is one of those things to where even though you and I experienced the exact same event, we have completely different interpretations and completely different manifestations of that trauma, right? So even though we have all experienced trauma, you're never going to be able to know exactly what the person has experienced. And so if you are working in that area and somebody is dabbling in that, don't ever tell them that I know what you're going through. I've done this. I've seen that, that's person I know. It's such an individualized thing that we, even if, like we said, saw the same event, been at the same natural disaster, we're going to interpret that and feel that in our bodies 2 different ways. The other one that's pretty bad for people is specific phobias. Why that doesn't take as far as the severity when we're talking about some of the other disorders is because if you can just avoid clowns, you're going to be less symptomatic, right? So if I have a phobia on clowns or spiders, as long as I just don't see that or get exposed to that, I'm not going to have the symptomology or the assistance that somebody else with generalized anxiety would. So specific phobias are pretty bad, but like I said, as long as we can just avoid those things that you have phobias about, it isn't going to be as impactful on somebody's life. Okay, so moving on. So let's talk about signs and symptoms. They are different. We chatted a little bit about this earlier. So when you are working with individuals, the one thing that you can do is pick up on signs because these are observable and can be seen by others, right? Where symptoms are typically something that must be conveyed by that person. They're either conveyed via speech, require some questioning and listening on your part to get those out, right? Some symptoms you can maybe see, but like a headache, you're never going to know unless the person's, curled up in a ball with their hand on their head, holding it, right? They would still even have to tell you because that maybe look like internal preoccupation. Are you hearing voices? Is it too much for you, right? Even if we do get some signs with the symptoms, we still have to ask some questions to gather those and get those out. So the signs, the first thing we can do is look at the individual's appearance. If we're first meeting them, that's going to be kind of more of your judgment call on what you think, right? Are they disheveled? Are they unkept or are they put together? And that's also going to be a cultural thing as well, where we can distinguish is for those people who we've been working with, right? We know that they dress a certain way. We know that they pay us the hygiene, and now that's changed, right? Now their hair is not done. Now their appearance or their clothing is kind of messed up or not ironed, or it looks like it has stains on it, whatever that may be. As far as their appearance, maybe they appear to be dirty, or there's an odor, right? But that's not how the original presentation was. Those are one of the obvious signs that we can all look at, is how are they appearing today, right? Are they going through something based on that appearance? The other one is going to be their behavior. You know, are they quick to anger? Are they quickly triggered? Are they feeling defensive? Is this something where they're a little bit more hostile or paranoid? We can judge all of those things based on how we know that person. If you're just first meeting them, again, this is going to be your first introduction. You're still paying attention to it. You're just not going to have a benchmark or something to compare that to, right? There's also nonverbal cues. Okay. We all know what somebody looks like when they're sad. Okay. We all know how somebody looks like when they're angry. These are things that, whether you're a baby, you were typically born with, right? But there are other nonverbal cues that we learn from society. We learn the flippant ways of being like throwing up your hands, right? You're not born with that, but you know, if you're answering somebody and they're like, you know, it's probably not the best sign for a nonverbal cue. Okay. We also know the difference between somebody who is angry versus somebody who is potentially violent, right? The balling up of fists, you're curling in your arms, that looks a lot different than I'm yelling and screaming and I'm pointing, right? So even then we can get some different on like where the person's at in there based on their verbal cues, or nonverbal cues, we should say. Verbal cues, and this is also for us too. When we are talking to somebody and we're asking and we say, how are you doing today? And they say, terrible, right? That is the obvious verbal cue. You also want to do some of those verbal cues as if you're listening. And I know everybody has asked that question once or twice, not really prepared for the answer or wanting the answer. Maybe you did that in passing, just being polite, and the person was like, oh my gosh, let me tell you about it. Okay. So when you are listening to verbal cues, hopefully you have the time for the answer, right? Because you may not know what you get when you say, how are you doing today? And they tell you, let me tell you about it. And then you get it all, right? So verbal cues are going to be things that on your part convey that you're actually listening and that you're paying attention. Those are the nodding of the head, right? Matching somebody's story. If they're saying something that's sad, acknowledging that that's sad. If they're saying something exciting, you're acknowledging that it's exciting. But they're going to have verbal cues to let you know if they're checking out, if they're done, right? What that may be. The other thing we can pay attention to is their rate of speech. Are they talking like the micro machine guy, or are they so fast and that you can't even understand what they're saying because they're so nervous, and right? Or are they really slow, really drawn out, and it's like the clear eyes, the guy from the Visine commercial, right? So rates of speech matter in that. And that's something that we can pick up from signs. How are they talking? Are they an anxious person, or are they, sped up on caffeine today? What is the difference? How are we going to know that? Okay. So rate of speech, if you know somebody, can either be a tell that they're not doing well or they're doing better, whatever that may be. The other one is tone of voice, right? When we talk about on a scale of tone of voice, there are more submissive, where you're just talking like, okay, well, whatever, like it's soft, it's kind of, you're not putting a lot of bass. Then there's aggression, where you're upset and angry and you can hear that. We want to maintain in that middle ground of being assertive when we're talking with individuals, right? And that is a good indicator on how well somebody is doing, is their tone of voice. So you can pay attention to those signs and symptoms, or things that you can pick up on. When we talk about symptoms, though, they're things that the person feels internally. Okay. Are they feeling hopeless? Are they feeling worthless? Are they feeling like they don't have a purpose? Those are things that you're going to have to ask questions to draw out. You may have peaked up your spider sense based on the signs that you saw, but in order to accurately gauge their symptomology, those are going to require you to say, how are you feeling internally, right? Elaborate when you say that it's not good. What does that mean, right? You want to draw some of those questions out. And how we talk to somebody maybe make them a little bit more. I don't like the why do you feel that way? Why are you doing that? Why are you dressed like that? Anytime you ask why questions to me, that can come across as a little bit defensive, or I have to explain to you, I have to justify why I feel that way. Well, I feel like that way because my life's crappy right now, right? Like I feel that way because a person just broke up with me. versus how are you feeling is more of a descriptive way, right? So even if we are asking those and pulling them out, there are little tips of the tricks to say, what is that like for you? Help me understand those, right? There are other ways than saying why. Okay. So if you can get away from the why questions, the other signs and symptoms are going to be aches and pains. And we'll talk a little bit more of those on slides on how those manifest. But if somebody is anxious, they're most likely going to have some issues somewhere, whether that's a balled up neck, whether that's a shoulder, whether that's stomach pain, whether they feel like they're, potentially having some heart issues, whatever that may be, there are going to be aches and pains associated with that. And if you're doing warm handoffs with PCPs and you're taking people to appointments, we'll talk about how to kind of bring that up or maybe suggest that maybe there's something else going on when we're looking at physical elements. The other ones that, even though you can see, has anybody seen anybody who is internally preoccupied? Have you seen somebody who looks like, I got one hand raised? Christina, how did that look to you when you saw somebody who was experiencing hallucinations? What did that appear to look like?
They sometimes would just tell me. I would ask them a question. It took a longer time for them to respond. They would be talking to themselves. One of them would use a woman's name and say, "No, I'm not going to do that right now. No, you F off." And I would ask her who you're talking to. Um, can you let me know what she's saying to you? And then she would say, "This is the person's name, and she's saying this to me, and I don't like her, and she's mean to me."
Yep. So the signs that you recognize, right, were response latency. It took several seconds to pass before, right? You had said that the talking to self or talking to others that weren't there, right? These are all signs. But what we have to gain is, who is that person? What's going on? Are you seeing things? Are you hearing things,
Mhm.
right? Paranoia is like that too. You can see darting around, looking around. I'm looking at everything. I looking at my exits. I appear to be kind of uncomfortable, right? But you still have to ask some questions. Do you feel safe? What is
I
going on with
ask
the person?
her, "Did she tell you what she wants?"
Mhm.
And yeah, so that's it. Sometimes asking what do they want? What's your
Are
and
there
then she had told me that I had a relationship with this person and they hurt me, and that's why it really hurts to see them there. You're not. And at that time I just told her, I said, "Well, if I saw somebody who had hurt me in the past, that would be painful to me too."
Mhm.
You know, um, just to try to keep her talking is what I was hoping to do on that matter.
Yeah, some other ones that we would use too is worried about command hallucinations, right? Are they telling you to do something and do you
Right.
feel obligated to do those, right? So
Yes.
those are more of the symptoms that you have to pull out to gather that, right? So they require some sit down discussion in a private, not a lot of stimulus going on, and we want to draw those things out. We know maybe what they look like, but you're never going to assume and never going to know 100% unless you ask those clarifying questions.
And sometimes I will ask if they've got a TV on or something else going on. It's like, "I want to give you my full attention. Is it okay if we turn off the TV?" And normally I get a response of, "Oh, thank you. Yeah, go, I can turn off the TV,"
Mhm.
because I don't, that's just going to take them, it can take them longer to respond, but it's also, when I address it like that, I can start it out of, "I don't want to be distracted from giving you my full attention." And it's just a way to show my respect for them at that difficult time.
Yep. Well said. So hallucinations aren't typically a symptom of depression and anxiety, but why would somebody who is depressed or anxious potentially develop some psychotic symptoms? Why would that happen? Any guess? So one of the things that can turn into is if I am not sleeping, and I haven't slept for multiple days, right? They'll do these studies in the military. If you don't sleep for 72 hours, you're probably going to start hallucinating. So if I'm working with somebody and they're, having a hard time and they're severely depressed and they're anxious and their sleep's been affected, okay, that's worth knowing. How long, how much sleep are you getting? How many hours, what is that? Because that could easily turn to more of a psychosis issue when, if we get their sleep under control, that will be less of an issue, right? Or not of an issue at all. The other one that we have to worry about, and we'll get into this later, is thoughts of suicide. You can have some signs, they're giving their personal belongings away, they're writing, talking about death, talking about or listening to, media or other things about that. So there are certain things that we know from our experience on signs, but in order to properly either assist somebody who is potentially suicidal, it's going to require a lot of talking and very specific ones that we'll get into here in a little bit. So I got another one, because their needs aren't being met. Yeah, that's a possibility. And they may be hyper-focused on what issues are bothering them and keeping them thinking about it over and over. So getting stuck in their head and just perseverating over and over. Yeah. Go ahead, Christina.
I have many clients on my caseload. I'm a GOSH housing provider, and many of them use substances. Some are honest with me when we do a harm reduction discussion. Others are not, but sometimes I can come in, I can clearly tell and sometimes even what substance they're under the influence of.
Yep. And that's the other area we run into, right, is self-medicating. And so had they been self-medicating on top of not eating and sleeping, and now they're using substances that may push them over the edge for that. So drug-induced psychosis due to the self-medicating of that, or the co-occurring disorder on top of their depression, anxiety, right, is also a factor to keep in mind. So signs and symptoms of depression. This is one of those that gets misdiagnosed. It's physical, right? I don't have any energy. Maybe I have low testosterone, right? I'm not sleeping. Maybe I'm too stressed. I'm not eating. Maybe I have something wrong with me, right? I have a headache. If you're a female, maybe irregular menstrual cycles. I have all these aches and pains. So I go to my primary care doctor, right? They do scopes, they do tests, they do blood work, they do all these things. And then they tell me, there's nothing wrong with you, Cameron. And I have to say, well, that's weird because my head hurts. I don't sleep. I don't have an appetite. I got this weird, I think it's a migraine. I've never had those before. And they say, well, sorry, there's nothing wrong with you. We tested you. We did all this, maybe it's because I'm depressed, right? So some of these things, when it comes to physical, they never get to the point of seeking out treatment because they only come to the medical standpoint of there's something medically wrong with me, right? So you can have physical complications, you can have physical problems, you can have phantom pains for untreated depression. So that is one thing that we have to keep in mind when the people that we're talking to are telling us all these terrible things that are going on with them and how they're feeling bad or they're feeling, constipated or whatever the issue could be. It may be also their mental health on top of that. So that's the one area that I do when we're talking about the signs and symptoms of depression, is that they can be physical. You can have physical problems attached to that. And sometimes we never get past the medical issue of that. So it may be worth checking out a counselor, doing some type of intake, or doing a warm handoff to more of a clinician person rather than a medical person. So then behavioral, this is one of those signs that we all see, right? You all know crying spells, okay? We can see somebody who gets up and leaves the table and goes withdrawals into their room. We can see somebody who's neglecting their responsibilities. They've lost interest in their personal activities. They do art. They don't want to pick up a pen. They don't want to pick up a crayon. They don't want to pick up a paintbrush. They don't want to do any of that, right? Somebody who's into exercise or getting out, they haven't done a push-up, they haven't gone to the gym, they haven't gone hiking, they haven't done any of that stuff for a while, right? So there are behavioral ones that we can see, and those are the more obvious ones for us on, okay, maybe there is something here, okay? So pay attention to the physical and behavioral, but there are also the psychological ones. Start talking and asking more of those questions, okay? When we start talking about sadness, anxiety, guilt, mood swings, lack of emotional responsiveness, feelings of helpless, hopeless, or irritability, okay? I would throw worthless in there. Some of those things we can see, others we're going to have to ask. We're going to have to talk to them about, right? whether somebody is frequently self-criticizing themselves. Maybe they're blaming themselves for their entire life, right? I'm here at this moment because it's all my fault, right? Intense feelings of guilt based on their decision making. They didn't do A, B, and C right. If I just would have stayed in school, or if I just would have stayed in that job, if I would have stayed in that relationship, things would have been better. Whatever that is, okay? Pessimism, impaired memory, they can't think about the things correctly. Recalling things starts to become very difficult. Their concentration and focus, they appear to be confused. They see themselves and others' systems in negative lights, and they start talking about death or suicide. These are all psychological things that we can either see a little bit of or draw out, okay? So when we talk about signs and symptoms, they're not just psychological, they are behavioral, and they're also physical. So we have to keep those things in mind for both depression and anxiety when we talk about those. Those are more the depression ones. We'll talk about the anxiety ones also. So signs and symptoms of anxiety, okay? When I am telling you that my heart is pounding, I'm having chest pains, I'm feeling or blushed, my face is red, I have a rapid heartbeat, what would that say? What would be the first thing that you think about? If I didn't know the person they were telling me that, I would think they have a heart attack, right? I would think,
Yeah,
oh, wow, okay.
I would probably think something physical.
Mm-hmm.
I would probably think that you were experiencing, like you said, like a heart attack, um, something like that. Maybe a panic attack, but I would probably think physical first.
Yeah. Well, and to think that if I'm telling you those things, right, and all of a sudden I'm already having troubles in life and additional issues, and I'm feeling anxious, and now I'm worried that I'm having a heart attack, right? So for the person, let alone for us to look at it, it gets pretty scary, right? Same with the respiratory issues. If I'm breathing super fast and I got shortness of breath, I'm thinking, oh my God, am I going to pass out? Am I having a stroke? Like, what is going on here, right? So the physical symptoms from anxiety can be extremely scary to the people witnessing them, especially to the person experiencing them. If I'm thinking of having a heart attack and I'm having a stroke, right? All of a sudden now I'm feeling neurological symptoms. I'm being dizzy. I got a headache. I'm sweating. My pits are all everywhere. I feel tingly. I think I'm going to fall over. Those are scary issues, let alone the choking, the dry mouth, stomach pains, nausea, vomiting, all the aches and pains, right? So when we talk about the physical symptoms of anxiety, sometimes they will mimic other problem that make it either worse for the individual because now they already don't feel control in their life. Now they're having these issues on top, and now I'm going to perseverate on potentially having a medical emergency on top of my other just normal anxiety stuff that I'd already been going through. Okay, so keep that in mind. And there is no real way that you're going to be able to say, well, you're not having a heart attack because you don't know that, right? So if the person does feel like they're losing consciousness or that they're having a heart attack, we still have to treat it as such. And we can provide some support in the meantime while either fire EMS or 911, or if they're at the doctor's office, wherever they're at, we can provide some support in the meantime while still getting them checked out. Okay, so let's talk about the behavior signs and symptoms. So for anxiety, one of those things too that is easiest is how many of you are worried about public speaking? Is that something that this group really enjoys?
I do.
Do you like it?
It's because I don't know, when I went to college, I wanted an easy class, right? But I was like, okay, public speaking, that's an easy A, sweet, and I took it and I was actually quite good at it.
That's good. How were the other people in class?
Like they were like the teacher definitely tried to give us tools, right? So if you're fidgety, if you're having anxiety about being up there, put a pencil in your hand, put your hands behind your back while you're standing at that podium. Some people just did not like grasp that concept of using tools to help your anxiety go down. And I took 3 years of it. So by the time I was done, I was really actually quite good. Didn't need a script, cue cards, nothing. Head up, looking at everybody, scanning the room, and really But then again, I used the tools that the instructor was giving to reduce the anxiety. And
Yeah, and that's really good. And
Yeah.
that is that's a huge skill for life in general, right?
Yeah. But I think that it's like a far different cry for somebody who is naturally able be to be in that position, because for myself I get a little anxiety, but I'm okay. But my daughter absolutely freaks out when she like thinks of any type of public speaking. She is a senior in high school right now, and she's taking a hip hop course, and the instructor is probably close to my age. So we're probably like that first generation of hip hoppers, and we have like this infinity for it, and you know, and we want to dive right in. So he wants her to write a rap and get in front of class and do it. And I think that this is probably a midterm project, but she is already like completely freaked out about doing it, where I'm like, "Ooh, that sounds like a lot of fun. Like, I would love to do that."
Mhm.
But I'm also sensitive to the fact that she is not me. You know, she doesn't have like the same, we just don't have the same makeup, and she's just not comfortable in going in front of people. And I know that she's like a lot younger and she doesn't have some of the tools that I have, but for her it's like complete panic,
Yeah.
and it's something that's so far off. And I'm like, you know, it's so far off, you don't have to be stressed out about it now. Like that's like, you know, the midterm and you guys just started school. But for her, it's like, oh my God, this is a project that I'm gonna have to do. And she's stressing out about it like now.
It's almost like you guys are plants. Like I planted you in there for my next point too. But you're both spot on with that. So it seems super easy, right? You just get some steps, just get some practice in there, right? Just use these tools, use these tips, and use these tricks, get this experience, and you'll be fine. Sometimes that's how we view anxiety, but that is the most common thing that most people have some form of fear or anxiety about, is public speaking or being called out or embarrassed or look stupid in front of people, right? Now, we can all make sense of that based on the public speaking. There are some people who get really nervous about that, but some people, that's their life in general. And that's the experience that you were just talking about your daughter, is the fear of it coming, right? Man, and she's already symptomatic and it's not even here yet. You're like, that's like 30 days away. She's symptomatic now, thinking about it, right? So that's really what happens for a lot of people when they start having an anxiety disorder, is that it's there with them all the time. Whether the issue is occurring 3 months ago, whether it's occurring 3 months from the future, it doesn't matter. They're dealing with it and thinking about it right now, right? So it seems, and it gets a little bit dismissive, and I'm not saying that any of you guys did that. You're doing exactly what, and that point was exactly what I was going with. That, hey, just go to therapy, just do this. It takes a little bit more than that, right? To deal with some of these things. Well, just learn how to breathe, just do 4 square breathing. Yeah, but that doesn't help when I'm racing thoughts and I can't even calm down to breathe, right? It's still coming. So sometimes people will just avoid situations in general. They just will tap out. I'm just not going to do it. It's easier to just not do that. I'm just not going to go to hip hop class at all, right? I'm just not going to write the rap. I'm just not going to do it. Okay. That's where we all feel some form of either nervous and have learned tips and tricks to get over it, where there are some people who are so stuck in it that just giving them those quick fix Dr. Phil kind of things aren't going to work for them, right? They're going to bow out completely. So whether somebody is obsessive about it, compulsive about it, thinking about it over and over and perseverating, avoiding social situations, behaviors, the easiest thing that we can see is their behaviors. They're just going to, with all their might, avoid that situation. So that's one of the things that we can see with our own 2 eyes. The other one is going to be psychological for that. And that's going to be unrealistic or excessive fear and worry. And that's kind of what you guys were talking about, right? You're worried about it and you're embarrassed or you're fearful or all those things. The event hasn't happened yet. It doesn't change the fact that whether it's about past, future events, I'm still racing. My mind is still going. I'm still filling blank when you ask me a question, right? I don't have the energy because it's been drained thinking about this and dreading this all over. I have impatience now and I'm angry and confused, and all these things can happen when you're trying to talk to somebody or trying to work through it and you're not getting the response now. So those are going to be the psychological things that we see that could even manifest in dreams. It can manifest in sleep disturbances, so on and so on. So when we talk about these things, please be mindful that they can run the gamut from the physical, run the gamut to behavioral, and then all the way to psychological. So that's a little bit more complicated than just trying to tell them, do this, do that, you'll be fine. Questions, comments, concerns so far before we move on? Thank you to those who helped. So let's talk about risk factors, okay? Now, when we talk about risk factors, typically people want to avoid developing them in the first place. And that makes sense when we're talking about children, right? How much can we stop a kid from having a traumatic experience in childhood? But there are certain ones that we can't, and there are also ones that are going to happen later on in life and continue happening. So the easiest thing we do is wrap our brain around children when these are a lifetime problem. You will have risk factors throughout your entire life, and those risk factors may change. And what I mean by that is if we're working with the geriatric population, they may have had family and friends. Well, now their family has family of their own, and they're taking care of those little kids and not visiting them anymore. They had a support structure, but maybe that support structure is passing away due to the age, right? Or they had a purpose in life and it was work, and now they don't have that work. So even though you may have limited risk factors in your early adulthood, as you get later on in life, those risk factors may come back, right? So this is going to be across the spectrum that we have to think about when it comes to depression and anxiety. There are people who have just knocked it out of the park and been successful, and then they retire and don't know what to do with themselves, right? I just saw a gentleman who multimillionaire, has great family, great kids, doesn't work anymore. He doesn't have a single purpose and doesn't know what to do. He doesn't want to play golf. He didn't play golf, right? So tell him to pick up a hobby. He don't want to do that, right? So now getting out of bed makes him anxious. Now he's starting to have more of these crisis type symptoms associated with that. So when we talk about risk factors, I don't want you to think too much about just limiting those risk factors that happen in our youth and not acknowledging that there may be risk factors throughout the whole spectrum of life, right? So when we talk about those, and this can either, one, make somebody develop depression and anxiety symptoms, or it can worsen pre or existing ones, right? If somebody has had a bout of depression early on in life, does that make them more likely or less likely to have another one later on in life?
I feel like probably more likely.
Correct. It is. And that's same with anxiety too. If you've had a bad bout of anxiety in your early life or at some point in life, it's safe to say that you can have one again, right? So we have to remember that too, that it isn't you got over it and you've recovered, now you're fine. That makes more sense when we talk about substance use disorders, because relapse is such a big part of that and prevention, where we think sometimes that if you've gotten over your bout of depression, you've done this before, you've already been here, you've already gotten over this. Why is it going on again, right? So none of these things, it's not a linear journey, right? So you can go back and forth. So when we talk about risk factors, the one thing that we will all have is stressing or uncontrollable events. You're going to see a tsunami. You're going to see a natural disaster. You're going to have the date come around where you had a divorce or that your dad passed away, right? Or the date that trauma occurred. There are going to be distressing and uncontrollable events, and that is the one thing that you can't control, right? Same thing with traumatic events. We also have to be very cautious of what is traumatic for one person. Doesn't mean it's not traumatic for me, but it could be completely traumatizing for somebody else. I've got permission to say these things when I talk about them, but my wife is one of those type of people who is so much more emotionally impacted by things. When that Sarah McLachlan comes on and the songs of an angel, she's about ready to cry, or she'll hear about a natural disaster across the world. Those people who are more emotional in nature, right? So that far one on the bottom, more sensitive, emotional in nature, we have to peak up and worry about those people when stuff like this happens, because they are so much more impacted by somebody. I'm like, you don't even know those people. You don't even know those animals, right? To her, it's a really sad thing. Okay. So difficulty in childhood or history of childhood anxiety, we talked about that one. You're more likely to suffer those in adults if you had an issue of that with in your youth. Ongoing or persistent stress. If you are tapped financially and you can't get ahead and every single bill is getting past due and you pay one and there's two more to pay, right? If you are stressed and it doesn't even matter, this could be a medical issue. This could be issues at home with your kids. This could be an abuse issue, whatever it is. If it's consistent and it's ongoing, that's going to be a major factor for developing depression, anxiety. The other one is comorbidity. We talked a little bit about that. One disorder will bleed into other issues in life, which can cause other disorders, right? So comorbidity is a risk factor as well. Previous episode and family history, right? If you've seen it and you've experienced it, you are probably nature and nurture gets affected in that. You are far more likely to be at risk for depression and anxiety. Any questions on risk factors? This is a small list of many different ones. When we were developing our crisis kind of checklist, right? Like a mini mental status exam. Some of you guys have done those, but like a crisis risk assessment, we put risk factors in there. When we went into the jail and provided services into the jail, we gave the jail risk factors. Because if I just got arrested and my name has been lambasted in the paper, and now my ability to maintain employment, my ability to work, my reputation, I'm also going to have fines, like all of these things, boom, 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 boom. My family may be affected, you know, so on and so on. I'm going to be far more likely to need observation or be at risk for something than somebody who wasn't. So we have to think about all those risk factors when we are dealing with people. So keep those in mind. So how to help? One of the best things that we can do is listen non-judgmentally. And I'm going to be very honest with you, listening just in general is difficult. Most people are waiting for their turn to talk. They're waiting for you to stop talking so they could tell you what they wanted to say. And they were barely listening to what you had to say, right? That is not what we should be doing in a helping profession. When a helping profession, we should be listening for thoughts and meaning, right? We should be listening not only that, which is difficult, but listening non-judgmentally. We are going to hear certain things that are going to offend us. We are going to hear certain things that we don't agree with, right? Does anybody believe that you cannot provide assistance to somebody who's committed a heinous crime? Does anybody think they just can't do it? Treating a racist, misogynist.
Well, for me, honestly,
Mhm.
it would be a lot more difficult for me to work with someone who is racist. Um, I might have more compassion and be able to work with someone who maybe made a mistake in committing murder. Um, it I I know that I would view things differently, like depending on the circumstance, if it was self-defense or, if it was like involuntary manslaughter or what have you. But I would be able to kind of look at that from a different perspective, because it may not have been a purposeful thing, whereas racism is purposeful and avoidable if you want it to be.
Okay.
And it stems from hatred and intolerance. And I have like less tolerance for that.
Mhm.
I don't know if that makes sense or not, but
No, it
it
makes
would
perfect
probably,
sense.
yeah, it
Yeah.
would probably be harder for me to deal with the racist. Yeah.
So here's the thing with that is that we all have biases. It doesn't matter who you are, right? And we all have what is acceptable for us and what is not acceptable. That means that you're just human. Okay. So you have to have a realistic expectation. And if you can't work with a certain population, you can't work with a certain population. That's where you have to have the self-awareness to tap out and maybe give that to somebody else who's more capable of doing that. That doesn't mean anything bad on your part. The point is that you should have some awareness into that. Now, the flip side of that is that we don't have to agree. We don't have to accept, right, the act, but we want to create an environment to where it is acceptable, right? And that I am going to give some key kind of feel, and can I work with this person and can I assist this person in the meantime? Because it may be in a short period of time, right? So we want to make that person feel respected, accepted, and understood. The point that sometimes we have a trouble with when we encounter a population that it's like that for me with sex offenders, right? Especially when you have children, and I have children, that's a really hard population for me to wrap my brain around and work. But I can still validate that person. I can still understand them. I can still affirm them, and I can appreciate at least that they're a human being, right? Without having to have those things affect me. So it does take a lot of compartmentalizing to deal with a population. On top, when I'm just trying to deal with your depression and anxiety and help you, and you're making racist comments, that is extremely hard to do and listen to, right? So to listen non-judgmentally is extremely challenging, extremely difficult. So if you've ever seen somebody do it, because I guarantee that that person didn't enjoy doing it, right? But they still showed some form of acceptance. They still showed some form of genuineness or empathy. And you can use some nonverbals in that, regardless of how you feel in your brain, because you're going to feel enraged. You're going to hear some stuff that maybe isn't the best to hear and that you would never hear. And if you were out with your friends, you might punch them out, right? But we can still be attentive. We can have comfortable eye contact. We can use open body posture. If they're seated, we can sit with them. If they're standing, maybe we can stand with them, right? That we're not fidgeting. We don't appear to be nervous. It's the same thing where I like to think about this. If you're talking to me about something, I don't want you to mirror my nervousness, right? I want to portray being calm, cool, collected, even with my speech, my tone of voice, how I'm standing. So that person initially mirrors that and calms down with that, right? So the one thing that we can do to help is practice listening non-judgmentally without our own bias or without us getting upset, which, like I said, very much so is hard to do and takes a lot of practice. And you do have to be realistic to that, and you're human. So if you do encounter somebody who has a past or continually says and does things that are infuriating to you or repulsive, whatever that may be, right? You're human. Maybe then we say, I'm not the best person to work with you, and I know somebody who probably is a better fit to do that, right? So if you cannot listen non-judgmentally, we need to think about a separate option, right? So again, how to help. One of the things we can do is a lot of people are being told what to do. They constantly are told, you should do this. You just need to do this. Just listen to this guy on YouTube. Just take this pill. Just exercise. Just do whatever and you'll be fine. We're very good at telling people our opinions and what they should do, right? So giving information and reassurance is hope with facts. It is not the same as telling you what I think, right? So one, we can treat that person with dignity and respect. We can try not to blame that person for their symptoms, and we can have realistic expectations. If I tell somebody who's struggling with homelessness, just get a job, that's not a realistic expectation, right? Maybe they don't have a safe place to stay. Maybe they don't have somewhere to lay their head and their belongings won't get stolen. Maybe they don't have transportation. Maybe they don't have an ID. Maybe they don't have a birth certificate, right? So when we're trying to help people and we're giving reassurance and information, we have to make sure that the advice or the info that we're giving them is actually applicable to them, that they can actually do that. We have realistic expectations. We also want to offer emotional support and consistently and understanding so that we say, even if they're not ready for that information, that I'll be here and here's the contact that when you are ready, or if you're interested, you can do that, right? The other one is provide some practical help. If a person's hungry, give them something to eat, right? Don't tell them where to go for that, right? So there's some of these things we can do for rapport building and actually establish some care that we actually give a crap, that we're not just going to be another person who hands them a resource card and tells them to get on their way, right? So that's the other thing we can do for depression and anxiety. The other one, so what is probably just as important is what isn't supportive, okay? What is, so the one thing that is those quick fix. How many times have you ever been in a dispute with somebody and they told you to calm down? Did you actually calm down when they told you to calm down? When you were in a fight with your significant other, they said, calm down, be reasonable, snap out of it, right? So do not say the quick fix stuff and try your hardest to avoid those type of things, right? Because I'll give you a hint, nobody ever calms down when you tell them to calm down. Okay. The other one is try not to be hostile with your comments or sarcastic in nature. On the flip side of that, we also don't want to be that person's savior and the only one who can ever help them, right? The only one who ever listens. So we have to be very careful that we're not adopting an over-involved or overprotective attitude with this person. We also don't want to constantly nag them. Giving them information and leaving that information and leaving the door open isn't the same as telling them repeatedly, did you do this? Did you do that? Well, you didn't. Last time I talked to you, you were supposed to do this. Did you do that? So you're not doing any of these things. You need to do them, right? We don't want to nag. The other one is we don't want to trivialize. Everybody knows a one-upper where they tell you something and then somebody else says, that's nothing. My cousin did A, B, and C, right? Or one time I had to do this and da. So we never want to trivialize somebody's experiences, and you want to use disclosure for your own in a supportive way and limited to appropriate to topic, right? We don't want to just be telling our stories and telling them all the terrible things that happen when right now they're the ones who are trying to convey that to us. Again, in patronizing tone or resist the urge to cure somebody. I'm trying to get through these so we have a little bit more time for question and comment. So self-help strategies, okay? Here are when we're talking about encouraging people. The one thing that besides encouraging professional help is self-help. Is that person into exercise? Would relaxation or meditation? Do they have family? And that can be not just birth family, that can be their family that they've chosen and given that title to. Their friends, do they have any type of faith whatsoever? The one thing that I have a hard time with is when missions or programs have a specific faith that you have to do, because that may not be the faith that that person practices, right? So there's nothing wrong with having faith, but only telling them that this faith is the way to go. Everybody has a different form of that. So faith in general, peer support group doesn't have to just be like AA, NA. That can be different people like Al-Anon, that can be NAMI, that can be a bunch of different support groups that we set up, even book clubs. I mean, name it, whatever that is. We want to provide that person with a social network to where they have some camaraderie and some culture that can help kind of pursue that. And they have a safe place to either talk, safe place to vent, safe place to get other ideas from people who are dealing with that with us. And that's probably those of you who are in peer support, why you have such a movement and why there's such a need for that is so many times people are talked at, they're not talked with, right? And that's what some of these support groups do, is they talk with them rather than at them, okay? So professional and other options when we're talking about services. So your therapy, if you are needing it on your own, right? Some of the times we're going to get triggered too. And even though this is more about the clientele or the population that we are serving, we are human beings that are also affected too, right? So don't hesitate to where if you are struggling with somebody that you are, if you're not engaged in your own therapeutic relationship, that you are asking your employer if they have any stuff that's through there or somebody that they can help with an EAP program or maybe refer to or other stuff. So keep that in mind. You can always go out to private practice or an agency that is a BHA, a behavioral health agency. If medication, which I don't take a stand on either or, if medication is a simple tool, that's all it is. It's like showing up to, if all you do is take medication, you're showing up to the construction site with a hammer, but you didn't bring your hard hat, you didn't bring your tool belt, you didn't bring a screwdriver. So medication does have a purpose, but it's not a cure-all, right? And all it does is help with the symptoms of that specific disorder or that specific issue to make it more able for you to cope and deal with some of those other things. It never makes it just go away, right? So sometimes medication has its purpose depending on the person and depending on the philosophy or whatever that is. but it is independent. If they are going to want to go the medication route, we want to make sure that that is either like a MAP provider, a medication assisted, somebody who's going to supplement something out, or a primary care physician. A lot of people I talk to prefer seeing an advanced nurse practitioner because nurses have better bedside manner, they say, or they're nicer. But a psychiatrist does the exact same thing. The only difference is they are a doctor. They have an MD degree. And then nutrition is involved, whether you do nutritionist or whether you get on specific diets for it, or whatever ailment they have or what would help, right? Some people have Crohn's, some people have issues with gout, some people have medical issues that certain type of nutrition will help with their depression and anxiety, let alone their medical conditions. And then you also have therapeutic massage. You can do acupuncture in that, whatever that may be. But when we're talking about professional options, we want to clarify, are we talking about self-help, or are we talking about professional and clinical when we give those? So the most common issue that's going to occur with depression and anxiety is going to either be non-suicidal self-harm or risk of suicide. So when we are having to go here, right, and maybe we've seen some signs, we've asked a little bit of questions, they've given us some stuff that peaked up the radar that we're worried about this, right? You need to ask the question as clear as possible. We don't dabble around it. We be very clear when we're asking this. Are you having thoughts of dying? Are you wanting to kill yourself? Are you going to? The more clear you can ask that question, the better, right? And if they do say yes, we want to follow that up with, do they have a specific plan? Do they have intent to carry out that plan, in what time frame? And do they have means? If they do, and you go through that and they have a gun, for example, where is that gun? And if it's on their backpack, on them, we have a different issue, right? Our own safety may be in there. So the more clarifying questions you can ask, especially when it comes to threats to self or threats to others, the better. We never want to leave that person alone, and we always want to report our concerns. We're never going to keep that quiet, and that's usually in a lot of offices when it comes to confidentiality. We can keep anything safe, other than the fact if you're going to harm yourself or you're going to harm others or vulnerable people, right? One is non-suicidal self-injury, and this can make a lot of people upset when their loved ones are cutting, biting, and burning, but they go get assessed and they're saying that's a coping skill. It is a coping skill. It's just a negative coping skill. It doesn't add value to your life, right? So when we're talking about non-suicidal self-harm, that is self-harm that isn't intended to end their life, but it's intended for a specific purpose. So some people self-harm because they don't have control over their life. This gives them some control. Some people don't feel anything and they feel numb. There's the pain pleasure principle. I cut myself, it releases endorphins, I feel something, right? So the reason why is important, not the act itself. So if you are working with somebody who is scratching, biting, burning, doing these things that are self-harming, focusing on the act and saying that's bad is not the purpose. We want to find out the reason and the cause of that and see if we can supplement something else in there. If they don't have control of their life, let's figure out some ways to gain control and how you can feel like you have that, right? If they are feeling numb and they don't feel anything, how can we help with that issue? But simply removing that from them and not replacing it with a better coping skill or one that's more appropriate for long-term gain, it's going to be a little bit more harmful than good sometimes. So real quick on your emergency, your crisis system has been merged to 988 now. So if you are having a behavioral health emergency, do 988. If it's a medical emergency, 911. It's not going to be harmful if you call 911 for both, but you can, if not everything arises to imminent danger, you may want to call 988 for those potential issues that could turn into crisis as well. And that brings us to questions, comments, or concerns in a minute. Sorry, I tried to get there. And leave some time for conversation. Feel free to critique anything too that you disagreed with. Thank you, Oliver. I got the chat up if you want to put that in. If not, feel free to unmute yourself and talk a little bit more.
Well, I just want to thank you for the session. It's been quite informative. I appreciate it. I don't have any critiques at this time.
Think about it later on. You're like, he should have done this. You let me know. I can take it. You got a thick skin.
We do have a survey that we send along with the slides, so feel free to put anything in there.
Cool.
Okay, sounds good.
All right. Well, the work you guys are doing is extremely important. And I appreciate the fact that you are here to do it because there is a workforce shortage. So everything that you're doing matters. And please be kind to yourself and those around you as well while we're doing it.
Thank you.
Thanks.
Thank you guys so much.
Thanks.
Bye.
Bye-bye.
Bye-bye.
You.